Our next session centers around mental health care and how VA is driving innovation in this field. To set the stage for this session, please give a round of applause to Suzanne Shirley, Director of Community Engagement and Fellowship for VHA Innovation Ecosystem, who started her career at VA as a clinical social worker and mental health provider at the Central Virginia VA Healthcare Facility. You're welcome. This you? Oh, yeah, we can go. I'll leave those. Did they turn me off? Hmm?
Hey everyone, it's great to be with you here this afternoon. Necessary conversations. We are going to have a necessary conversation here in this next hour today, and I'm so thankful that you have taken the time to engage this with us. I have learned that necessary conversations are challenging. And as part of being challenging, a lot of times what's happening in life kind of informs what you do and how you see things, right? So an artist will say whether they're producing 2D, 3D, media, music, what's going on in life fuels what's happening with what they're producing. So the same is true of me, although I'm not an artist. I have 4 daughters, and that tends to occupy a lot of time in my life. So what's going on with the 4 daughters can highly impact my thinking, and it highly impacts this topic of necessary conversations. Because I have had to learn, and am continuing to learn, every day I'm learning, how to have necessary conversations with 4 young ladies. Mostly teens. My oldest just hit 20, so mostly teenagers, and 2 of whom twins. So we've had necessary conversations about a range of topics. We've had necessary conversations about relationships, about sex, about you name it. I've tried to have an open door in these conversations with them. But watching their reaction and watching how they engage in this has been very interesting. My second daughter, Lily, she is she's probably the most sensitive to impression management and, oh, Dad. So we were having a talk that involved relationships and the S word and just open dialogue. And I always try in these talks to include food or drink, because everything goes better with food, right? Or drink. And I figured that'll just make us all more comfortable with this. So I remember in this conversation, my litmus for how uncomfortable Lily was the smoothie in front of her. It was a 16-ounce smoothie, and we start talking about the S word. And I am telling you the truth when I say her lips did not leave that straw from the top of that 16-ounce to the bottom as she just stared straight ahead and didn't. So if I see you in this necessary conversation, grab a smoothie and go from top to bottom, I'll know, okay, let's pause and take a little break here to talk this through. But necessary conversations, important. They can be painful. but there's a big need for them. And this necessary conversation also links in suicide and suicide prevention. Now, within that, let's talk a little bit about veteran suicide and suicide prevention. There's a need for this conversation. You can define or help to communicate that need by looking at direct impact. One way of looking at direct impact is to say over 6,000 veterans have died by suicide each year from 2005 until our present data in 2020. 6,000 a year, over. You could look at it from a perspective of indirect impact. From an indirect impact perspective, consider the fact that some research suggests that up to 135 people are impacted deeply by one suicide. And within that, suicide then becomes a risk factor at a different level and different way for them in that 135. So let's take a look at 6,000 per year for 15 plus years. And at this point, you're talking what? 12.2 million people who are impacted by suicide. Take a look at, although we've made some significant improvements, and you can see this in our Anchors of Hope in our annual report, and about a 10% decline the last 2 years in veteran suicide. 18 to 34-year-old veterans have had a 95% increase in suicide across 2001 to 2020. So there's a lot of work to be done within this essential conversation, and innovation plays a critical role within that. Now, innovation is nicely integrated in the here and now and demonstrated through Mission Daybreak, in a particular endeavor that we're engaged with some of you in here, and definitely with Kit and his team. And what this represents is important in terms of both process and outcome. From a process perspective, this represents innovation in that for VA suicide prevention, it's historically been very difficult for us to engage a process such as a grand challenge. When I took this role, I'll admit, I did not even know what a grand challenge was. Someone came to me and said, "Hey, Matt, what do you think about this grand challenge?" I thought we were talking about a video game, you know? I mean, is this some weekend retreat? What is a grand challenge? And come to find out, prize competition, and it's a thing, and it's a good thing. And we've learned so much along that 2-year journey. And part of what we want to talk about today and in this hour is how tools like that can significantly enhance innovation within suicide prevention. Outcomes. What do you think is the most common question that I face as Director of Suicide Prevention? Anybody got a guess? Hi, Dr. Boyd. Nice to see you. Anybody have a guess? Let's run with that. Let's work with that. Why? Why does it happen? It's the very first question that I was faced with when I was in an acting role here and they put me in front of the camera. Remember that episode of The Brady Bunch with Cindy Brady where she froze on the camera, deer in headlights? I know all of you in this crowd, you only saw it in reruns, but go check it out. I was afraid I was going to go Cindy Brady there. So the cameras come on, and all I'm thinking is, don't do Cindy Brady here with this opportunity. The first question that comes in my headphone is, why? Why does suicide happen? I'm thinking, I've got 2 minutes to respond to this, and that's a big question. Here's a short answer, though. It's complex. no one single factor, and what may be a risk factor for me at a certain point in time may be less of a risk factor for me at another time. So from an outcomes perspective, we need a lot of different solutions and a lot of different options. And that's also the point here with Mission Daybreak. Now, if we do this correctly, we have a lot of different focus areas and create a pretty broad theater of operations. And this gives you an idea of the range of areas that we're taking a look at. And essentially what we're saying is, here's Matt and the team's list of what we need help with. Help. What ideas do you have? And this gets us outside of, and nothing wrong with this if there's anyone from procurement here, but this gets us outside of the typical contracting and and it opens it up to a whole different group and population to participate. But you look at the topics and the variety there, and you can see that this is going to require, with this diversity of topics, a diverse array of solvers to come together. So this has gone so quickly, I can't believe this, but next week, we're at the point there in phase 2 where we're going to have our demonstration day, and we're going to be able to take an important step in starting the judging and evaluation process. In the end, that's going to have $11.5 million going out to first place, multiple first place winners. I think there's 2 first place winners, 3 second place winners, 5 third place winners. Where was that system when I was in high school? That's what I need. There's multiples here occurring, and all kinds of options with those solutions as well. So really looking forward to this and wanting to use this as a bit of a foundation, an anchor for you in this important discussion that now we're going to engage from more of a panelist approach regarding mental health, suicide prevention, and innovation. So with that, I think I hand it back to Susie to introduce our, I hope that wasn't for you.
No,
If so,
no.
stand here. Okay.
Thank you.
Yep.
Thank you, Matt. If you want to take a seat.
All right.
Now we'll move into our panel discussion. We have a great panel today. I'll go ahead and invite each of you up to the stage. Many of you heard Sonia's presentation yesterday. She is a peer support specialist or peer specialist out of Chicago, Hines VA Medical Center. Sure. And we have Dr. Amanda Purnell here, Jara Meter, and of course Matt Miller. So I'll go ahead and let the panel introduce yourself. Do you want to start?
Hello, everyone. I'm Sonia Ebo-Timmon. I'm a lead peer specialist at the Edward Hines Junior VA, and I'm glad to be here.
Hello, everyone. My name is Amanda Purnell. I'm a psychologist and the Director of Data and Analytics Innovation for the VA.
Hi, everyone. My name is Jara Metter. My pronouns are she and her. I am the Open Innovation Lead at the General Services Administration, where I serve as the federal government's point of contact for prize competitions, open innovation, and also citizen science and participatory research.
I think we've met.
Check.
Well, thank you all. I'm really excited for the discussion today. Thank you for joining. So to start us off, I'd like to refer back to some of the important remarks that we heard earlier today and yesterday on the importance of focusing on implementation. So that's different, from ideas and vision, as we've talked about, operationalizing innovation to deliver measurable value on behalf of veterans and with our veteran customers is not as easy as it sounds. And then scaling it can be even more complicated. So let's talk about that. So Sonia, do you mind starting us off? We had the incredible privilege, of course, of hearing your story yesterday and learning how your desire to support women veterans in mental health inspired your career at the VA. You spoke about the importance of including veteran voices as part of the development of new care models and mental health services, as opposed to involving them only in the deployment phase. So how does this human-centered approach to design and diffusion of innovation ensure that we're solving the right problems and developing really impactful solutions?
Thank you for that question. One of the things I really have to hone in is the veterans that we serve are adults. And I don't know about any other adult here, but adults tend to do what they want to do. And when it comes to the recovery process, it's very important that we allow them the choice to self-direct what their recovery is going to look like. And by doing that, we have to allow them to take ownership of the projects and innovations that are coming through on VA. That gives them a seat at the table, self-directing, and then we as VA, we are to support them in their recovery process. By doing that, not only do we increase their confidence, increase their ability to go where it is they want to go in life, choose the community they want to live in, take part in those activities that they want to take part in, but we also give them a ground and standing room to keep further in their recovery process. In my work with a great women's group at Hines, Confident and Courageous, this morning, before I could even wake up, one of the group members called my VA cell phone to say, hey, we know you're not here this week, but we still want to meet, so open up the group. That says that what they have done is something that they really want to do, that they want to continue in that, and when we can allow them continue going, then they rely less on VA, and it opens up the door for VA to actually work with a greater number of veterans.
Yeah, thank you for that. And Sonia, tell us, for the audience, what is a peer specialist, a peer support specialist? What do you do?
So a peer specialist is another veteran who has already navigated VA programs and things, and my job is to come alongside other veterans and help them also navigate. We do a lot with working with the recovery journey. They hear me tell my story a lot of times to offer them hope that wherever you are at this very moment, you don't have to go that low. You'll never go that low. All you got to do is keep focusing on the goals at hand. And our job is to support them in that. My job is to advocate for services for the veterans, whether it's in VA or not. So I work a lot with community engagement as well.
Yes, ma'am. Thank you. So, Matt, I'd like to hand a question over to you. So, mental health service providers and clinicians are increasingly seeking new ways of working to improve quality in care delivery by increasing cost effectiveness and adopting new technologies and care practices. The implementation of these innovations and improvements has become an important focus across the VHA and the nation. So how is VHA working to address mental health issues and suicide through the broad diffusion of innovative technologies and approaches to mental health care delivery?
I think there's some really relevant examples of that. I think as a preface to talking about some relevant examples, I'll just say real quickly the importance of having these types of conversations and these opportunities to meet together and talk, because something can be innovative by technical definition, but there's a significant gap between the innovation and the operation and implementation. And if you don't cover that divide, then it's not something that's going to move forward in any meaningful way. So this is an opportunity for us to not just talk about innovation and examples of innovation, but how does innovation pair with VA policy, practices, and scalability sorts of issues so that it can really have an impact on the front lines level. Now, I think one example that we've been working on the last couple of years has been taking telemental health, taking clinical practice guidelines and taking what we know to be barriers to care, putting it all together and coming up with a solution that gets clinic practice guideline endorsed therapies to high-risk veterans with less of the common barriers, such as those that are secondary to geography or provider capacity. So how did we do that? We created a national system where we plug into what's called CRHs within the VISNs. And plugging into these CRHs, we then hired over 100 licensed professionals who are trained in evidence-based approaches to suicide prevention, like cognitive behavioral therapy for suicide prevention. Then they're providing that service as referrals come in from a facility. So Dr. Boyd is head of a network, a VISN. There's a CRH there. Is someone in a facility, a provider in a facility may say a veteran here needs this particular service, but we don't have it here, but our CRH does. Let's put in a referral to the CRH, and then we can patch into the veteran wherever, however, to get that service to them. So innovation, overcoming barriers, and using some of what we have, such as telemental health, to advance it.
Yeah, thank you. That's a great example. And so that kind of leads us into the next question for Amanda. Technology. Technology, big data, and innovation will impact the capacity and the expectations of the mental health workforce and the way that it's trained, managed, and deployed to support high-quality care delivery. So looking toward the future, how do we ensure that emerging mental health solutions for veterans, as well as their supports for their caregivers and clinicians, are evidence-based and non-burdensome and patient-centric so that they are widely adopted?
That is a packed question.
Yeah, it's like a performance-based interview question.
I want to really hearken back to what Sonia had to say about making everyone an owner. So the more we engage across the spectrum, that includes veterans who may be using resources, that includes their caregivers, that includes care teams of a variety of different trainings and backgrounds, in helping to design and develop solutions. It's been my experience that technologies exist to be used by humans. So any new technology that we're going to be adopting or testing or looking for in clinical applications, we have to figure out how the people involved are going to use that solution. And I'm going to go back to what Sonia had to say from the very beginning. So as we're beginning to understand what is the problem, we're asking the people involved, how do you experience this circumstance? How do you experience this situation? Deliberately asking questions across the continuum of users, deliberately seeking diverse opinions across different veteran groups, looking at different care providers, care pathways, different areas of the country. And as we look to adopting new technologies, seeing what people say, what they don't say, looking at their behavioral responses when they have that pained look on their face. Oh, I've tried to do this 4 times and I can't quite figure out how it works, and now I'm feeling like I'm a failure because I don't know how to use the technology. I think it's really having a learning approach and bringing everybody along with us. And because I love what Dr. Miller had to say, mental health and suicide prevention is far too complex for any one solution to fix it, that we're looking for multifaceted solutions and a multiplicity of partners to engage.
Yes, oh, I love that answer. And so when we're talking about kind of reaching out into communities and listening, both to understand problems, but also to understand how solutions are meeting the need or not, I'd like to ask Jara, for your perspective, digital health technologies, in here this portion of the panel will be talking about challenges and open sourcing, crowdsourcing. So digital health technologies and smart structuring of innovation ecosystems have the potential to move the multifaceted field of mental health care and suicide prevention forward. So what barriers need to be lifted to ensure progress in research and clinical practice to support digital transformation that meets the mental health needs of end users?
Yeah, excellent questions. Using your smoothie analogy, if you want to see a federal leader engulf an entire smoothie in one sitting, talk about innovation and how to fund it. I think that one of the barriers that we have for innovation is that we aren't operationalizing it effectively within the federal government, and so often we have these glaring examples of innovation theater that we're putting forward. And so in federal government, if you want serious people who care about the mission of the agency, and veterans in this case, to take you seriously, you need to talk about outcomes that you're seeking through this funding and how you're going to get there. One of the primary barriers is budget. We often talk about how much, we use the phrase, how much funding do we have available for innovation? Instead of, what funding do we need to achieve an innovation? And not just focusing on the front end of that innovation pipeline, but thinking about implementation and getting that sort of back of the napkin guess, because it really is a guess when you're talking about innovation, of what will it take to institutionalize this, to diffuse it in VA terms across the network, and to make it deliver value for veterans. So prize competitions, challenges, they offer an opportunity with the slide that Dr. Miller showed of this really deep, interesting funding construct of seeding and investing in innovation with the private sector. And I think that's a huge opportunity. Oftentimes when you talk to members of the private sector, and I do, and I ask them, why aren't you working with us? They'll say, we have no idea what you want. That solicitation was horrible. I do not want to work on that as it's written. And so being really clear about what we're seeking, how we're going to fund it, funding it using constructs that deliver equity for our private sector partners, community-based organizations who support veterans every day so that they can get going quickly. So reduce those burdens in how we're funding things and fund things appropriately. The other major barrier we have to innovation within the federal government is that we're kind of antisocial with our data. We hold it, and we don't have to always. And so really educating our leaders about synthetic data, all the types of data, the way to de-identify data, ways to adopt really innovative and forward-looking participatory sharing mechanisms around data structure, data management, and data access. Put your data out there and then measure who's engaging with it and how they're using it, and tell them when it's out there and where to go get it and work with people. So I think if we can really focus on how we operationalize our budgets to fund innovation in ways that create equity with our partners, and then also create frameworks for open science and open data that are meaningful and that we can measure through engagement.
Yeah, thank you. Open science and open data. I like that. And when you think about, to your point, the way that traditional contracting is done, the way that the contract's written, assume that we know exactly what we need. But really what we know is we know the problem that we have and we need solutions. So I think that, open data, open science, these challenges are a great alternative to how we look at solving these problems and engaging communities in doing so. So Amanda, back to you because I have another digital question. How can digital mental health care models be incorporated into existing models for clinical care at VHA to deliver high-value, connected care for veterans? And further, what impact does the adoption of innovative technologies in mental health and suicide prevention services have on access to care and quality of care?
You do have really great questions. So I think there's a lot of opportunity in thinking about the adoption of technology, digital health technology, to advance mental health systems. In order to do that, there is a necessary component of really understanding the current systems and care pathways. What does it really look like right now? What are the touch points of a veteran's journey across those various care pathways? And who might be the person who would be able to adopt and derive benefit from a particular digital mental health solution? What I'm particularly curious about in terms of the question of access is, how do we define access? Who is the person that we're defining access for? Is it our definition of access, or is it the veteran's definition of access? Right. So as we think about designing solutions, really thinking about what is it that the users want in terms of connection points, and how would they define success? Would they define success as, I was able to get on a call with a provider within a few minutes, or a text message and got something back? Or do they need a visit? Sometimes we make assumptions about what access means, and we create a whole system of measurement around that, and it may not be actually what people want. So really understanding what the needs are as we test and adopt digital health solutions, and that we are really able to collect meaningful information in order to understand what is the impact, whether it's improving quality of life and mental wellness across the user base, for whom are there different populations that benefit greater or lesser from that particular digital health solution, and then understanding who might be left out or who may not be interested and may need other solutions.
Mm-hmm. Yeah, that's so important. And, so question to Matt, about the current state, mental health treatment services in VA. How can treatment outcomes be maximized by combining existing treatment options, and these are medications, therapies, et cetera, with the digital mental health interventions for suicide prevention?
Yeah. I think so many important points. I'm sitting here and soaking it in and learning, but so many important points have been made. And in case you don't know it, I'll tell you, she just wrote a textbook to you in terms of things to pay attention to bridge the divide between the non-federal and the federal in this area of innovation. I don't know if you all have had this experience, but it kind of reminds me of what it must be like to go to one of those fashion shows in New York or Paris or Milan, and you're sitting there and you're seeing what's being presented and you're thinking, how am I going to wear that? And how am I going to afford that? And how would that be produced in a way that I could provide that? It ain't happening. So yeah, it's kind of cool to look at, but what are we going to do with it? And I think making sure that we're having these conversations, that we're bridging these gaps in that way, because there's a temptation to think something new, something flashy, something fast, something that offers new charts and graphs. You gotta love it. And yeah, you do, but then how am I gonna use it? How is the MSA on the front lines going to use it? The provider on the front lines going to use it? Now your question gets to a really important point that I think Jar made, and that is outcomes. So not only do you have to talk about scalability, but you have to be able to talk in terms of what outcomes do you have so far, how is this set up and designed to help us evaluate outcomes, and if the conversation just completely ceases at this and goes blank and goes back to, but look at the noises it makes and the bells and whistles, there's not a lot that we can do with that. So looking for ways that innovation can be integrated for care teams to use it at their fingertips, and then for that information to be integrated into broader healthcare information that's digestible and interoperable. Very, very important, or else it's not going to get anywhere. I'll make one more point for primary care providers that I've learned and want to pass along with regard to this. We were talking about an innovation not too long ago, and it had to do with an interface. It was called a GUI, and a GUI applied to the health record. And ran it by some primary care providers, and they said, that's more clicks. And so we're looking at it and saying, what, it's 3 extra clicks. And they're saying, do you know what 3 extra clicks means for us? Yeah, 1, 2, 3. No, that's not what it means. And so we did a time study and found out that 3 clicks is meaningful within a 20-minute appointment with a veteran. So that GUI is out the window then in that particular case if it's going to add 3 extra clicks. So making sure that we're having these conversations, bridging the Paris runway with the Saginaw VA front lines, and working together to do that.
Yeah, thank you. And you know, I mean, to your point, it's never as simple as just taking a new technology or a new app or new capability and just using it. You know, a lot of what we do in innovation and the work that your office is doing is about building care models together, you know, co-development, starting on a small scale, building that process and that infrastructure together that actually enables VA to consume technologies in a meaningful way. And with the proper documentation and data then so we can study the outcomes and see what's working.
Can I add one more
Sure.
thing, or if I
Yes,
talk
please.
too much? She said yes to both, so.
Yes, please add.
I do want to add an aspect of responsibility here. So there's a lot of things that fall under innovation that we can offer veterans and say, here, try this, try that. But we also know from research that you only get limited opportunities to offer them something that doesn't work and have them come back and receive something else. Some research has suggested with particular elevated risk populations, that number is 3. You get 3 chances to offer something, and if it's not a match of right time, right place, right service, right intervention for that veteran, they could say, been there, done that, tried it, and they're out. So we can't innovate in such a way where we're building this cash and just throwing things at veterans and say, try this, try that, try this, try that. It's also got to be paired with not just outcomes of it in isolation, if you will, but outcomes with regard to how does it match with right time, right person, right place, right setting, so that we can better match it and not in effect strike out with our veterans.
Yeah, thank you. And I imagine, Sonia, does that resonate with you? I mean, in your direct work every day with veterans, do we get those 3 chances or?
It does, and that's why I keep going back to veterans need to be part of the planning process from the beginning, because those 3 tries and hope it works is not going to cut it. As we mentioned earlier, we have veterans who are leaving us by suicide daily, right? So if we can focus on what it is that they want, what it is their need, and VA is big on talking about veterans needing to partner and play active roles in their health care. when it comes to innovation, this is an opportunity where veterans can play that active role from the beginning. And again, I'm going to say, grown people tend to do what they want to do. So if we partner with the veterans and come up with the solutions, I really believe that 3 tries will go away because we are already starting on what it is that they want and that they need, and that's something they will tend to continue in their recovery process. So
Yeah. Yeah, thank you. So I want to leave a good amount of time for Q&A. So a few minutes, though, before we do that, I want to talk a little bit about leveraging open data models and meaningful partnerships to improve mental health. So Amanda, you've done some really exciting work in making data models accessible. So how is VA leveraging open access, privacy-compliant data models to accelerate evidence generation and implement data-backed improvements in care delivery?
I was really hoping you'd ask me that question.
Yeah.
After Jara was talking synthetic data and tiered access models, I was like, I really hope I get to talk about that too. So what the VA has been doing, and we have the capability to do now, is to create pathways for access at the right level of risk. So for an early stage idea, we're just testing something out, it's new, we're not sure how it's going to work, we can work with partners to share out a synthetic or artificial version of that data that doesn't have any of the real data in it. If there's something there, then we go to the next level. Then we share out either a limited, de-identified data set, or we bring that solution into the VA and test it within the VA firewall. And we begin by making it easy to access, something we can more readily provide and partner with both external partners of a variety of sorts, whether it's academics, nonprofits, small startups. And then we sort of increase over time the level of personally identifiable information to develop the solution further with more complex data sets. So rather than going through the fairly lengthy and complicated process of assuming we need the whole thing from the beginning, we begin to learn right away. And we can then develop and iterate over time. I will note that I'm very excited to work across the government with incredibly talented, smart people who are building out the handbook and policies on how we do that work so that it's repeatable and not a one-off project every time where we have to complicatedly execute a plan of action for every single project. So I'm really excited about the enthusiasm of other governmental partners to help work to build an infrastructure to make this process repeatable and reusable across many different projects.
Yeah, thank you. It's amazing what you and the team have done with building this opportunity for data. Jara, part of your role is focused on crowdsourcing innovation through prize competitions, of course, and broad agency announcements. What lessons can be learned from the implementation of those programs, and how can agencies like VA apply those lessons learned from the success of federal and other partners who've adopted open innovation practices?
Yeah, as far as lessons learned go, there's an adage that says if you want to go fast, go alone, but if you want to go far, go together. And I think partnerships are one of the areas where agencies have really started to use open innovation in effective ways. More than 60% of all federal prize competitions run in a year are done so in partnership. But one area where I really want to challenge federal agencies is to think of partnerships more as weight-bearing activities, where each partner has a distinct role that is complementary but doesn't overlap with the other partners on the team. I think by doing that, we can leverage the talents and the resources of this collective and lead to greater sustainability and implementation. Matt keeps setting up these great analogies and thinking of your palette of analogies and metaphors, thinking of your runway model. I think about that. That is what a partnership is like. There are models, there are designers, there are the people who run the lights and create the environment that allow that activity to happen. With prize competitions in innovation and government, if you want to be impactful, you need to find all of those people in the ecosystem who care about an issue. Mental health, it's supremely important to bring all those powerful and important stakeholders, veterans, into the conversation about innovation from the very beginning and often through iterative processes to ground truth the innovative ideas you're bringing forward to make sure that this is what veterans want, this is what the ecosystem can support, and this is what we'll implement, and then measure that implementation with those stakeholders. The other lesson learned that we've seen with innovation is that most federal agencies don't actually define innovation at their agency, and I can tell you, at every federal agency, innovation means something different because every federal agency has a different culture. It's like a different country. It's really kind of interesting. And so I think agencies should do this work across their agency to define, based on their mission and their capabilities and their teams, what is innovation, and then plaster that everywhere so that everyone can be part of it. VA has done incredible work with this through the Innovators Network, right? And Spark Seed Spread and funding models that are grassroots. So define innovation at your organization and then take it one step forward when you're putting it into practice through your funding models. Throw out, disregard all of your procurement evaluation criteria when you're funding innovation and use innovation criteria to source those innovations. Because what we know from prize competitions is when you do that, you'll bring those innovators that work in adjacent fields to that problem. You'll also bring innovators who don't have that long history of innovating with the federal government. They don't have that track record, but they're excellent. They're the people you need to be working with because of their resources and what they're doing right now. And bring them in. Design your criteria to find them and award them so that they can keep doing this great work with you. And so, yeah, I think partnerships and I think defining open innovation, putting it into practice, and then practicing it with your innovators through how you select them and reward them will lead to transformational innovation that you're seeking, especially around mental health.
Yeah, thank you. And we have been so lucky to have your guidance and your support through these different kinds of challenges that we've offered here. Now, we're running short on time, but Sonia, I would love for you to close us out here. I have one final question, and don't worry, it's not multifaceted. I'd love for you to tell us, as a veteran, customer of VA, and someone whose VA career was inspired by the need to change VA services, how will we know when we've made it? I took that from Carolyn Clancy's talk earlier. How will we know when we're offering the best, most accessible mental health care for veterans?
I have to look at the outcome. So I think VA will know they've made it when the veterans that we work with utilize our services and take what we give them, all of the resources, all of the skills that they learn, and go back out into the world where they live, work, and play, and implement those same skills, those same resources in their daily lives. Essentially working us out of a job in their lives, but leaving us open to help other veterans that are coming in. And we know we're always going to have veterans. We're always going to have veterans. So I'm looking at the outcome, what's happening with the veterans that we have touched.
Yeah.
And how VA has supported them and how VA has impacted their lives. Because one thing's for sure, one veteran will talk to another veteran.
Oh, yeah.
And that's where we made it.
Yeah.
It's not that VA won't ever have anything else to do, because there's always going to be, one veteran, no, one Marine, no. But what are the lives of the veterans looking like?
I like
Do
that.
they feel supported?
I like
Has VA impacted the service that they provided. One of my colleagues always says he took the time to serve his country. When he got back, his country served him through VA. And that's how we serve other veterans. So, and I'll give him a plug. That's Michael Rowland, peer specialist.
All right, all right. Yes, ma'am. Thank you very much. So we have a few minutes left. I'd love to open the floor for Q&A. I see a hand right here. Greg?
Yeah. Hi.
Oh, we have a mic for you right there, too. Thank you.
Duke Strategies. My question is for Dr. Miller, and it refers to the chart you put up in your introduction with the objectives for Mission Daybreak, one of which was engaging the family in support of the veteran. Now, we know that the family isn't part of the VA mission, and we know that the VA isn't resourced for families. So how do you square the fact that the family is the ultimate stakeholder in the care of the veteran and intuitively essential in providing a life support system for the veteran when it isn't explicitly mentioned in the mission nor resourced for, nor do you want to inadvertently give the impression that the VA will resource families?
Great question.
So I'll just tell you what my initial thought or reaction was and kind of go from there. My initial thought, Greg, was we start with, I want to say correcting, but I don't want that to look like I'm talking to you. But we redefine the VA mission in such a way where people are not misunderstanding that it does not involve the family, because the family and the community, we're learning this in suicide prevention with a public health approach. The socio-ecological perspective is absolutely critical. It's imperative to incorporate within everything that we do, from clinical care in the VA to other services in the community. So the family is part of our mission. The family does need to be involved in the clinical care process, as well as involved in community endeavors. Now we have the Staff Sergeant Parker Gordon Fox Suicide Prevention Grant, where we're offering grants to community organizations and entities, including those that are providing services to family members. And that's another way then of taking this a step further and demonstrating family is part of the mission and critical. I hope that answered your question as a starting point, Greg.
It's a great answer, but the family is not, as you know, explicitly in the mission statement. And I think that is for good reason, because we don't resource it.
Yeah.
So I think part of it is somehow engage the family
Yeah.
as essential
Yeah.
in a practical way, given the resource constraints.
Yeah.
And I think, for example, VA caregivers already do that, right?
Yeah.
So it could be done.
Yeah, and I think it's how you bake it into your process and system. Like, how can we bake it into what we're doing for safety planning in the emergency department? How can we do this for risk ID and our universal screening and paying attention to that? And that's what we are working on and doing. Now, as for overtly putting it in the mission statement, I have full control of that. I'll get on that this afternoon.
Right.
And you should see changes by 5.
Thank you for that question. Yeah? Let's see, we have one there.
Hi, my name is Dr. Maya Carter. I'm Director of Virtual Care Integration for the Office of Primary Care, and I'm a primary care physician. Thank you for this discussion today. I am all about the workflow, how to operationalize the innovation and make it come alive on the front line, and with our clinicians, our non-clinicians, and with our veterans. And so I wanted to understand your perspective on the orientation process. So once we get something developed, orienting clinical and non-clinical staff as to what this is, how does it work, and how it becomes effective for our patients, and then what language to use to educate our patients about this. And then the feedback loop of, okay, is it working, is it not working, what happens when things go wrong? So as a clinician, it's always like, well, what do we do now? Who do we call? Is the vendor, where do we go, right? To keep the conversation going, we want to keep the sustainability, the interest, the motivation. So interested in that perspective. And also on, do you think we're getting closer to the place where, as a clinician, I can pull up an electronic health record and really see pharmacological and non-pharmacological options for my patient, and be able to really incorporate in my assessment and plan all kinds of different virtual tools and things, mobile apps, patient-generated health data, so it's all there. And I can see this comprehensive perspective for the patient. Are we getting closer to that?
Thank you for that question.
I'm not sure who it was to, but I'll talk. I'm going to keep referencing Sonia's genius. We tend to get more effective engagement when we begin with ownership and empowerment, and that those then owners, the veterans being served, the care team that's testing, the medical center facility that's kind of the early adopter, that they're in from the ground, and that then they are the ones who are sharing their stories across to other facilities, rather than that spread occurring from a directive or a memo. People tend to respond very poorly to directives and memos. Again, I'm going to go back to what Sonia had to say. People tend to be self-directed and like their own ideas much better than they like the directives that are handed down to them. And the second part of your question that's very different, I will also try to answer, because I feel like there's a lot of interest and curiosity in how we test out the use of technology to encourage adoption of new modalities of practice by embedding those new options in our current workflows. So I'm hearing that conversation occurring, which gives me promise and encouragement that we will see more pilots of that kind of work occurring. And I know within the Office of Healthcare Innovation and Learning that there are active efforts to do some of the very things you're speaking of.
Yes, thank you. We have gone a little bit over. I'm getting the cue to exit. Thank you so much to everyone on the panel, and I think maybe we could be available in the back for a few minutes. I know there were a couple more questions, so big round of applause for the panel. Thank you very much.